talking about health effects, what's important. I have some general comments and issues to make. And a good starting point, I think, is actually Eloise's summary slide, which is even smaller. One. Okay. So we're going to talk about what health effects are of concern, and I think from different perspectives. So, if you put on different hats, if you're a policymaker, you might care about some things. What about if you're a parent? You might care about your child's asthma. Or if you're pregnant or your spouse is pregnant, you might be worried about having the healthiest possible child, of course. And if you are a pulmonary physician, you might be worried about asthma and chronic obstructive pulmonary disease. So there's different perspectives that are important. And there's some questions here. So my friend Kiros is now going to talk. Kiros, you are speaking to a policymaker. He's done a very important epidemiological study, and he's found that the risk of dying, which we don't want to die, is increased. The relative risk is 1.05 per 10 micrograms per cubic meter of PM 2.5. Anybody who's ever read the epidemiological literature has seen things like that. And now Kiros is going to explain what that means to everybody in the room. Let me give you your task again. 1.05 hazard ratio, I'll throw in a technical term, per 10 micrograms per cubic meter of PM 2.5. And I'm able to ask him this question because 28 years ago he was a postdoctoral fellow with me.
So I'm back to being a student again, right? Yeah, so, well, wearing my statistician hat, I could go on about hazard ratio and how to derive it and so on and lose policymakers. But the best thing to do is actually to wear kind of a communicator hat. And I think someone actually in this room said it very nicely. It's actually good to associate it with something that people understand readily. So people know that smoking is bad for you. So I know there are hazard ratios and relative risks that are actually already known but are associated to smoking. So if you can say, living in a polluted environment is like smoking 2 packs of cigarettes and actually have the evidence or something like that, actually people will relate to it very quickly. So try to make it as digestible as possible and as relatable as possible so that people could understand without minimizing the cost. So I think that's how I would approach it. Yeah.
What about 1.05?
Well, I mean, it's 1.05 is kind of 5% increased risk. So you can quantify it in relation to a population base, for instance, right? So out of 100,000 people, then the 0.05 excess relative risk or odds ratio or hazard ratio, whatever you're fitting, will translate to this many people dying. So that way, actually, again, you're quantifying it, but in a way that's not just abstract numbers. I hope.
Yes. Anybody can help. He needs help. He needs help.
Let me also make an attempt. Thank you very much and good afternoon. Good morning in Colorado.
Okay, right.
Yes, the 1.05 people who are exposed to 10 micrograms. Those are tiny, you can only see them with a microscope. Very tiny, tiny particles, 10 micrograms per meter cubed. If you take a meter like that, you have a meter cubed, 10 of them there. So you take the population in that quadrant where they're exposed and compare it with a population without 10. Then you'll find that the risk of dying, which means even those who are not exposed will die anyway. That is there. Yeah? But when these are dying like 100, those who are not exposed, the ones that are exposed, about 105. Is that correct?
Well, you're on a right track.
Yeah.
I think what you've seen is this is not easy.
Yeah.
Okay. And a long time ago, in 2000, we published a paper that was supported by the Health Effects Institute. And it was a very important paper. And my way of explaining this was that this extra risk, which was in our study, I think about 10%, translated in Chicago into an extra death on a day that was more polluted. I mean, you have to look for something like that to explain these things. So there's what health effects we care about, and then there's how are we going to explain it. So these are Eloise's summary points from today, which I thought were really good. So economic budget impacts. So that's actually taking that extra burden of disease and saying, how much does it cost? So if somebody dies, the economic cost is actually what it costs to lose a life early. Okay, if a child is having an asthma attack, more asthma attacks, you can cost that. So that's translation. Here she talked about the need for data, and we're going to come back and talk about this a lot, the low-cost sensors. And would you use those for epidemiological studies? Some of our colleagues in the room are doing just that and saying, how much indoor air pollution is there? And going on, general public misunderstanding of what air pollution is, where it comes from, and what it does. And we're going to be sort of on that theme in this next half hour. And how do we all collaborate? One thing, is anybody here a communications expert? Has anybody studied communications? I'll take that as a 0. Okay. And then let me ask another question. How many of you have talked to communications experts about air pollution and telling the story of air pollution? Some have. So let's see. Tell us about your experience. Let's see. Where's Victor with the microphone?
So my personal experience with talking to someone with experience in comms was that part of the information I was giving to them, the straight knockback I received that this wouldn't be palatable to like a general audience. As you said, avoid things like the numbers. What do they mean? So this needed to be broken down, and I found it as an expert in quote-unquote air quality. I found it as a humbling experience that what I was presenting, the comms person said, Gabriel, this can't be taken up. So we had to work. It was a briefing. So we had to work back and forth. The data was rigorous. We followed a lot of ethical protocol, calibration, etc. But to me, it was humbling that someone is telling me that, this is tricky if you're taking it to a general audience or policymaker. Yeah.
It's a very useful experience, and I think every time I talk to communications experts, I realize how hard it is and how bad I am. And that's a good thing to realize, I think. So I think the important points here. So let's go on. So what are we worried about? We want to make sure that we're dealing with risk from air pollution. And we want to be healthy. We would like to be as healthy as possible and have as little risk as possible. And I'll just put this definition up because I use it all the time. A thing is safe if its risks are judged to be acceptable. So what do we do when we're doing research? We measure risks. And who makes the judgment about whether the risk is acceptable? It's all of us, right? It's not the scientists. It's everybody. It's our policymakers. So part of when we think about what health effects we're going to worry about, then it's the ones that we don't want to happen. Does anybody here want to die early? No. Okay. All right, got the answer. The answer, of course, is no. What about dying a day early? Is that okay? Not okay. A year early, is that okay? No. Okay. All right, so those are the kinds of things you have to think about. So looking at health effects are of concern, I sort of started on this. You have to sort of put on different viewpoints about what may be important. So to the public generally, no one would find it acceptable that babies are born weighing less, or that babies are at risk for premature birth because of air pollution or tobacco or anything else. To policymakers, what might be important? Everything? Anything? My policymaker speaks.
John, everything is important for as long as it benefits the last person. Have I answered you?
You've given a definitive answer. Okay, so we'll see if you can stick to that, though. Okay, fair enough, because that's hard. So if the policymaker says that, so we're going to come to this. To parents, everybody who has a child can put on a parent hat and say, I don't want my child to be at risk for respiratory infection or for asthma or for a smaller lung because of air pollution. And then there's many different groups. Maybe those of us who are older don't want to be at risk because of age. And you can keep making a list. So I think in thinking about what health effects are of concern, there's one other issue that's been an important one in the U.S., and that is, what is a bad health effect? What is an adverse health effect? So there are probably, right now, if you did a search in the literature and said, how many studies are being published that use epidemiology to address air pollution this year, last year, how many studies do you think there were? Were there 10? Were there 100? 1,000? Think there are 1,000? Thousands. So I think the last time I looked, there were over 2,000 studies, just air pollution and epidemiology in a year. So we're covering a lot of territory, and some of them say things like, as PM 2.5 went up, and then there'll be some biochemical measure. Interleukin 6 rose by so much. And is the change in some biochemical measure an adverse health effect? In the GeoHealth Hub that we've talked about, there's going to be a study about thickness of the carotid artery, which is the artery that takes blood up to your brain. And air pollution is associated with, linked to narrowing of that artery. Okay, so if the air pollution accelerates the narrowing of the artery by 0.5 millimeters per year of exposure to PM 2.5 at, like the thing that Kiros tried to answer, is that an adverse health effect? And could you explain it? It's much easier to say, we don't want to die early. So there's a lot of different things. So one question that's come up in the US was, what is an adverse health effect? You can measure things. Is a small change in lung function an adverse health effect? So ozone, is there much ozone here, do we know? Not really. We don't know, or not really much ozone? Not much ozone here. Okay. Okay, from the data you have. Okay. So one of the ways that ozone affects the lung is that if some people are susceptible, and if they're exposed to ozone, their lung function drops a bit. It may drop 5%. Somebody goes out and works outside is susceptible. Then the lung function will come back to normal, back to where it was. So is a reversible change in lung function adverse? And would you regulate based on that? So Karati is going to answer that question.
First of all, I wondered, my first thought was if you have that all the time, I'm sure there's going to come a point where the lung isn't going to go back to normal. So that would worry me. And the second one is, I don't think you could regulate on that, because the monitoring that you'd need to see whether there's a change based on any implementation that you did would be really difficult. I mean, you need a pulmonary technologist to do lung function testing. And it's a difficult test when you have to blow into that thing.
So the U.S. ozone standard is actually, the 8-hour standard is based on lung function change, and it has been for a long time. And I think that's why we have an 8-hour with short averaging time, is to try and get at that. But I think your other point is that maybe long-term lung function change may occur if you have repeated episodes. Quiros was involved in a very famous study in Los Angeles called the Children's Health Study. And that study started with the idea that repeated high-level exposure to ozone, which was a problem in California, still is, would actually reduce the size of children's lungs. So continuing on, so there are papers about this, and this is one from 1985, and then it was updated in 2000, and then updated in 2017. And these may be resources, Pallavi and Victor, we should make available. They're just sort of useful papers for thinking about this. Now we're going to talk about what health effects of air pollution we care about. So I put this together a while, maybe 2 years ago, and it was all the different health consequences of air pollution exposure that had been studied. So if you look up there, there's all-cause morbidity, just not being as healthy. There's all-cause mortality. There's birth weight, miscarriage, getting worse with chronic obstructive pulmonary disease, inflammation, depression. Don't you think it's depressing if you get up in the air you can't see? Fair enough, it affects your well-being. Autism. There's been a lot of work on autism. And there's been work on so-called brain aging, diabetes, all those things there. So maybe we should take a moment and talk about which ones you think are important. So if you were going to launch new research studies here, what topics would be important to look at? There's a lot of choices, and you could add to the list, but these are some of the ones that have been studied. So why don't we take a moment and get thoughts about what health effects are of concern and use your perspective. Actually, Bruce, comment from your perspective as a pulmonary physician, what you would worry about and what you would tell patients.
Of course, I would divide the patients into two groups. The patients who have air pollution-related diseases and those ones who don't have. For the ones who already have the disease, I would be worried their diseases will get worse. Like the asthmas, they would get more attacks, their disease would be difficult to control. For those ones who are not yet, then I would be worried that they would develop the disease. Of course, asthma, lung cancer, COPD, interstitial lung disease, and allergies.
So along with, do you talk to your patients about air pollution?
Sorry?
Do you talk to your patients about air pollution?
Yes, I do.
And do you counsel them to avoid it? What do you tell them?
For the ones who already have the disease, we tell them to minimize exposure. For example, if you have asthma, you may not want to go to town at the peak hour. You can go at another time of the day. You may not be the one to cook the biggest meal at home. Of course, cautiously. And for all respiratory patients, doesn't matter which disease you have, you need to avoid air pollution. So we talk to them about it, especially indoor air pollution. But we don't give the prescription they talked about in the morning. We are not yet there. of the clean cook stove, say 2 clean cook stoves per week for 2 years.
And one last question, don't go away. If you were going to do a research study to look at these clinical issues, you know, how important it is to your patients, and that might be good for policymaking, that it costs money in general to take care of people who are affected by air pollution or they lose work. How would you do a study? Have you thought about it as a project? Speculate.
Yeah, we probably, as a clinician, I may not go that far, but again, as a researcher, I'm concerned. Because you know, as a clinician, you look at one patient at a time, and usually we don't over-extrapolate. But as a researcher, the economic impact of air pollution, we think about it when people miss work, when people spend on these illnesses when they are sick, and of course when life is lost.
Okay. And people do studies on things like being absent from work or absent from school, which are good outcomes that you could look at and that are very practical and that might be useful. Or you could follow a group of children with asthma and see how much school they miss when the air pollution goes up, for example. So you could explore those questions. What other health effects should we talk about that are on this list or others? And what studies might be done? If the Health Effects Institute offered a very large grant to do new studies on the health effects of air pollution, what would be important for the region? What study would you do? And how much money are you offering, Bob? It's endless. There's a new grant available for $2 million from the Health Effects Institute. Oh, he's saying no. Well, let's pretend there was. Let's pretend there was. What study would you do? What would you want to do? What grant would you write? What would be important? Would it be a study of autism? Would it be a study of birth weight? Would it be a study of stroke, brain aging, diabetes? There's $2 million available. Maybe.
A study on cognitive development, because from the other results, it was that HAP was affecting children less than 28 days. So we want to see from conception to 28 days, what are they, like in terms of cognitive development, is there a serious impact?
Okay, so cognitive development would clearly be something that would be adverse if it were affected. It's something everybody would care about. And it might get the attention of policymakers if parents said, we want to address air pollution because our babies are not turning out as well developed cognitively as they might have. So that's a good example of something might be done. What other possibilities? We have a speaker.
No, it's just a point. Doesn't it depend on what perspective? I mean, I have a daughter who has a vestibular condition, so I'd be interested in vestibular function. You know, that's a mum researcher who wants to push the envelope and understanding something where we're fighting and not understanding something.
So there might be many reasons. Having discussed this with you, would be a particularly challenging outcome, but the parent perspective is one I had on the slide before. It's important.
Okay, thank you. I think for me, I'd be interested in doing a study on the relationship between air pollution and allergies, the triggering of an allergic reaction. Yeah, because I think like her, I have a son who is always affected by, I imagine, air pollution. So, and it triggers his allergies and he coughs. And then when there is good air, he's very fine. So I would want to probably do check if there's any relationship and to what extent.
Okay, and in terms of eventually communicating the results, it would be helpful because it's something that people care about. So if you said air pollution makes allergies worse, I think people could understand that. It's better than the 1.05 hazard ratio micrograms per cubic meter. So, I mean, I think, you know, thinking about things where if you have a result that it can more easily be communicated, I think that's important. So whether it's, you know, babies are not as smart as they could be if we didn't have bad air pollution, which is your study, or, you know, there wouldn't be so much allergy if we had less air pollution, which has been studied. I mean, it's a very interesting connection, actually. Kyros.
Yeah, just to add, actually, going back to what we said earlier, in terms of added value and being complementary, I think, first of all, I think, you know, in terms of health outcomes, our focus on women and children, for instance, because they would be vulnerable populations, and they'd be the ones affected most, especially in the African context because of indoor air pollution, biomass sources, and things like that. So, and then on the exposure side, I would focus on not only ambient air pollution and just to replicate or duplicate what others have done, but really focus on the unique features in the African context, so that, you know, you can look at, you know, sources from many angles, right? So I think it's a combination of many things. Knowing HEI is not going to fund, you know, research that has already been done. So I think, you know, you also have to have the added value, but the novelty and the originality, but also addressing important questions. So.
Good, thanks. Yeah, in the back.
Thank you very much. On my side, if I was to be given an opportunity, I would go for air pollution and mental health. I think this is an area that has not clearly been addressed. So I would want to find out if there's a correlation between the emissions and the anxiety and depressions that comes as a result.
Okay.
Because we need a productivity, and we can't be productive if we are being affected mentally by these emissions.
And I will say, I mean, I can't comment on Nairobi day to day, but for example, I've spent a lot of time in China, and when you can't see one block and your eyes burn, you don't feel good. I mean, it really, and if you can think about getting up day after day after day and looking out your window and seeing air pollution and nothing else, I think certainly mental health would be, and again, something everybody can relate to, I think. So I think a good point. Let me ask Paul. 5 minutes. So
I would like to the researchers to do more research on autism. Autism, yes, especially for these early child development centers. Teachers don't know how to handle such problems, and yet they are there in the early learning child centers.
So great thought, and again, there's about 20 years of work now on autism and air pollution, epidemiological and also other kinds to try and understand why there might be a connection. And I don't know about the situation here, but in the United States and some other countries, there's been an unexplained rise in autism for maybe 30 years now, perhaps. And so, and again, in terms of outcomes that everybody would consider adverse, that you would want to try and reduce the burden, I think that autism is a very sensible one to pick, for sure. And this is, yeah.
I think since we have substantial amount of studies done outside the country and a few inside our countries, I would personally like to know about community perception of air pollution and the knowledge that is associated with diseases, because until somebody knows they can be impacted upon negatively, it doesn't matter how much you sing the song about the problem until you know the perception. So I know in Nairobi a few studies have come up and the perception is quite low, even among people who are affected.
It's a good point, and let me give you a different example. Some of us grew up in the United States when about half the adults smoked. And we were all exposed to very high levels of secondhand smoke indoors. And at the time, there was a widespread perception, to use your word, that that was okay, it was the norm, because it was. Everybody was exposed to tobacco smoke. On airplanes, in public places, in homes, in cars, buses, trains. Who has been on an airplane where people were smoking? It's an age question, but you really know. Can't be. Yeah. Oh, the pilot was smoking. Ah, okay. But, you know, I mean, I think your point, the point of, yeah, so I mean, I think your point of that there was a norm, and that norm was that you were just going to breathe in contaminated air. And then that norm changed. And I think that's important. So that goes back to this question of, yeah, of course we're exposed to air pollution. It's out there all the time. There's too many cars. You know, we're cooking at home with biomass fuel of some sort, and everybody's exposed, so it's got to be okay. So that perception is important. And again, research to try and explore what people actually know. Doing good focus group or other research might be very, very helpful at this point. And that could be with different groups. That could be with policymakers. What do you care about? What would influence things? That could be with parents. It could be with physicians, nurses, other healthcare providers, the public health sector more generally. And that kind of data collected might be useful. Let's see, the suggestion that research should also consider indoor air. And I would actually say that correct, of course, and they should look, and this came up in the morning, that you should look at all the exposures that take place. They're in buses, they're in cars, they're outside, they're indoors. And, you know, again, understanding sort of total exposure is really important. I'm just going to end. I have put something here that's a little bit off. Yeah, the brain issues are really interesting, and this is from about 5 years ago, an article in Science magazine. But let me, yeah, and I think we covered these things. Just one other point. I want to show you, we talked a lot about how do you go from doing research and move that to policy. And I think it was George, I'm not sure, talked about the silos. True? Talked about the silos. And, you know, I often talk to my faculty who do research, and they're very often frustrated because they say, well, we do this and nobody pays attention. Or we take our research to talk to somebody and they say, so what? And they're frustrated. I just want to show you, in the US, I think for air pollution, outdoor air pollution, we have a somewhat easy path. And I say that because there's a process for moving from the research to where our national ambient air quality standard will be. And this is the process. And don't worry about it, except that something like this actually happens. So every 5 years, our Environmental Protection Agency is required by the Clean Air Act, by law, to review all the new scientific evidence on what are called the criteria pollutants. You've heard that word used this morning. And those are pollutants where the standards are supposed to be evidence-based. And what the EPA does is to review the new evidence that's come in since the last summary, look at it, and see if there is a reason to make a change in the standard. And it has a whole process. So we're, as researchers, we're over in this end doing peer-reviewed scientific studies. And the Health Effects Institute, HEI, one of the things that it's done very well for more than 40 years is to do good research that is targeted to key into this process. And for example, with particulate matter, there were many uncertainties. The United States has had a PM 2.5 standard since 1997. And it started, there was a lot of criticism, a lot of work was done about critical uncertainties, and HEI looked for researchers to submit proposals to address those uncertainties. And it provided a number of important contributions because the process was clear and the uncertainties were clear. I think what this morning's session told me, not surprisingly, was that the processes aren't clear because they're not so well developed. And many other countries don't have very well developed processes. And I will say Europe is quite confusing. And the WHO guidelines are very useful, but what process you use to get there, if you're using them as a guide, is much more difficult. So I think what we're going to do is go do some work in small groups. So Victor Apollovi is going to tell us about this. So good. Thanks, and Kyros, I have some more questions for you, but tomorrow.
Thanks, John. Does anyone have a question for John? He's been asking too many questions.
That was my job. What
anyway, thank you. So I'm just going to project a list of groups. We've sort of taken the liberty to organize you all in groups. And we have moderators and rapporteurs. So let me just pull that up. So you may want to check your name and follow the moderator for that group. So our moderators are Lynn. Lynn is seated at the back. He is from Uganda. Dr. Karadi Wright, who presented this morning. Ivy from WRI Africa. Bruce, also seated at the back. And Gabriel. Gabriel is second to last. So the idea behind these groups, and we'll lean on the moderator to sort of steer the discussion. Is it too small? Okay, so I'll blow it up after I finish so that you can, just look at your name. So the idea behind this is we've had a broad discussion on what we think the issues are. So in the small group discussions, we'd like for you to think through not so much the problem, but more how can we get to a place where we are starting to deal with these issues in the short term, in the long term. What are the challenges, resource-wise, capacity-wise, et cetera, et cetera. So what you're looking at to get out of the group work in this 5 or so different groups is sort of like, how do we go about this? Not so much, this is the problem, that is the problem. We sort of have an idea. So that's the idea behind the small group discussions. So I'll let the moderators take it from there. There's rapporteurs as well. And I'll blow it up. So what we'll do, I think we'll, if you feel you would like to go outside, you're free to do so. But we do have this room for that purpose. So you can self-organize within the room, or you can sit on the nice, outdoor. We'll let you decide on that. So we will do, in the interest of time, it's now 3:30. Let's do 1 hour, then come back, report back, and see how we progress on time. So we'll do this for 60 minutes. So group moderators and rapporteurs, I guess you can, take positions and your people will follow you. Any questions? Anything that's not clear? We are good? So is it more efficient if I just read out your names and you know which groups you're in? Okay. Would you prefer that? I'll just read out names and you'll follow the group. So Lynn, you're the moderator for group 1, so that's Lynn.